Hi, good afternoon. The next topic, first of all, thank you for having me here. I think Madhu's made all of us read quite a lot for this. A bit unusual topic, screening for colorectal cancer. And of course, this has been talked about in surgical circles for a long time. Why talk about screening in India? 10 years ago, we were not talking about screening in any of our meetings. Why are we talking about screening for colorectal cancer? And why is it becoming a hot topic now? We know that colorectal cancer is the fourth and the fifth most common cancer in India, fourth most in males and fifth most common in females, as per the Globacon 2022 data. The overall incidence is still very low. It's about 5 per 100,000 population. But we've got a population of 1.3 billion. And so the overall numbers are still very, very huge. And so the cancer burden for colorectal cancer is increasing. We have all noticed younger patients coming to us. Data has shown all across the world that there is a 20 to 124% increase in incidence over time. And the 124% is actually more in the younger patients. So incidence in the older patients might be decreasing, but younger and younger patients are having colorectal cancer. And in India, if you see various series, the median age is actually 50 years. So we see a lot of younger patients. And so therefore, there's lots of concern about colorectal cancer. And so therefore, the natural progression is to ask the question, should we screen? Because the Western world screens. Just a disclaimer, there are no formal screening guidelines or policy in India at present. And what I am going to talk about is population-based screening. I'm not going to talk about opportunistic screening. I'm not going to talk about screening in high-risk individuals. We're going to look at what screening is. Is it really useful? What are the methods? Because in the first half of my talk, I'll sort of talk on the nuances of screening, because understanding the nuances is important to actually answer the question saying, should we screen everybody in India? And then we'll talk a little bit of the economics and then the challenge in India. So what really is screening? Screening is testing of asymptomatic people. And this is different from early detection. If people are symptomatic, we often say patients present late in India. They've been symptomatic for a long time. Detecting symptoms early is different from screening, because screening is in completely asymptomatic people. And the aim of screening is to diagnose cancer at an early stage. Or in colorectal cancer, even diagnose it at the polyp stage so that the cancer never develops. And the final outcome is that outcomes are improved. And in colorectal cancer, improvement in outcomes in two things. One is mortality from colorectal cancer is decreased. Second thing is, if we detect polyps and remove them, incidence of colorectal cancer itself will decrease. And can we achieve all of this in our population is what I'm going to dwell on. First question, does screening in colorectal cancer really work? Does it improve outcomes? Does the colorectal cancer rate go down? Does the mortality decrease? Multiple RCTs have been done on this. Here we look at a RCT done in the West, in Minnesota, where 46,000 patients were randomized into either annual or biannual screening with fecal occult blood, and one group with no screening. And if you look at this graph, patients who were screened, the cumulative incidence of colorectal cancer actually came down over 18 years. So as you screen again and again, the incidence of cancer itself comes down. Another large trial from Nottingham, 152,000 patients, again randomized into screening with occult blood or no screening. And if you look at 15 years cumulative data, the rate of cancer itself comes down in the whole population. Big Cochrane review looking at 7 of these studies, and it says that ultimately screening reduces the risk of cancer mortality. So yes, in large randomized trials, we have seen that screening reduces incidence of colorectal cancer and mortality. Now, if it does, what tests can we use for screening? The test really should be affordable, it should be acceptable, and it should be of low risk to harm. And these are the tests which are available: the fecal occult blood, the FIT test, flexible sigmoidoscopy, colonoscopy, CT pneumocolon, and some novel techniques. Now, when you look at this, you've got to see which of them are actually affordable, acceptable, and have low risk of harm. Which of us is something which we all will accept to say that, yes, if we have to go for screening, we are happy to have that done, even when we are asymptomatic. The guaiac-based fecal occult blood test is the most commonly used. The guaiac reacts with heme in the presence of peroxidase and gives a positive test. It has a very high specificity, but the sensitivity is low and it varies. Important point is that every single RCT that I pointed out has used guaiac-based test in their testing methodology. Now it has false negatives and false positives, and only about 50% of cancers can be detected by guaiac-based tests. That's because sometimes it can be false negative, tumors can bleed intermittently, and very distal tumors, the RBCs have not lysed and the hemoglobin is not exposed. However, it is cheap It is relatively easy to perform and more acceptable to patients. Now, the FIT test is immunochemical testing. It uses antibodies against the globin molecule. The quantitative test is what we use. The concentration of hemoglobin in feces is what we want to see and decide whether the patient requires further second-line testing. Now, depending on the cutoff that we use for FIT, you can have different levels. So, the higher the cutoff, the lesser chance of a false positive. The lower the cutoff, more chance of a false positive. But we have to strike a balance and say where exactly do we want to put the cutoff so that we don't miss out many cancers. And usually about 10 or maybe around 15 microgram of hemoglobin per gram of feces is what most studies have used. But again, this varies across countries and across studies. Flexible sigmoidoscopy is also a useful technique. It's said that one flexible sigmoidoscopy at around 60 years of age, if you find any adenomas, remove them, and that gives a good test as a screening test. Again, large trials have been conducted. The FlexiScope trial had 354,000 patients randomized to have a flexible sigmoidoscopy or not. And then finally, the screen group did have benefit. So you can see that the colorectal cancer at all sites in screened individuals does go down. So flexible sigmoidoscopy also works. Colonoscopy is the gold standard for detecting adenomas and carcinomas. It's widely used as an opportunistic screening modality. There are multiple studies again looking at colonoscopy. The biggest problem with colonoscopy is that it has a low uptake. It's difficult to convince people to electively have a colonoscopy. It has cost implications. You need expertise and equipment, and there's always a risk of complications like perforation. And if it's not done properly, it can actually be harmful because you can miss findings. CT pneumocolon, again, you can do CT colonography, less invasive than a colonoscopy, but still requires bowel preparation. You can pick up bowel lesions, but again, it is costly. It has high dose of radiation involved. It's not easily available. And as a population screening method, it really is not feasible, at least not over here. There are many novel approaches. You've got blood-based markers. You've got cancer detection by dogs. Dogs are able to smell volatile acids in either your breath or in feces or urine. And again, these are novel, not commonly used, but just for knowledge. So multiple tests are available. If we are going to do this in India, which one are we going to use? Which one is actually feasible? And the most important thing is which one is going to have a good uptake. Now, if you roll out a screening test and people don't want it, then the whole program has failed. Even in the West, there's only about 50 to 60% uptake on the fecal occult blood and the FIT tests. And if you look at colonoscopy and flexible sigmoidoscopy, only about 20 to 30% uptake. It's even less than that in some areas. And the uptake is not uniform across populations. So there are subsets where the uptake is more. But if you look at the underprivileged, you look at minorities, you look at certain areas, the uptake is even less. And even if people do the first level test, that is they do your FIT test or the occult blood, if it is positive, not everybody comes for your second level test, which is the colonoscopy. Only about 80% come. 20%, even with a positive test, do not come for screening. Big important thing is economics of screening. So ultimately, when you do screening, you're looking, and if it's a government-sponsored program, you're looking at the cost of preventing or treating one cancer. And then the cost is not just that. The cost is the cost of the test, the cost of subsequent investigations, the cost of people taking it, the cost of treating the disease, if it's detected early or if it's detected late, and then the cost of overdiagnosis and all those who are false positive. So there's a lot of costs involved. It's a very complex thing. I don't think as a surgeon I can understand the economics of this, but no, there is a huge economic aspect to screening. But overall, it's generally agreed in the Western world that screening is cost saving. So to quick recap, screening works. Multiple tests are available. The occult blood and the FIT are the most widely used. Uptake is low, but it's good for the occult blood and the FIT test. And the economics is complex. Now, keeping this background, what are the challenges to screening in India? And I'm going to put 2 or 3 points, and then I'm sure people will have opinions. These are what I have thought. These are what I have spoken to many people and sort of put together. But all your opinions are welcome as well. Now, the biggest discrepancy from the West is the incidence of CRC. So now this data is from Globocon 2022. This I got 2 days ago from the Globocon website. Now I have just put together 3 or 4 countries. So if you look at the whole European Union, the incidence of colorectal cancer is 80 per 100,000. If you look at US, where a lot of studies have come from, the incidence is about 50 per 100,000. The average world is about 20 to 25 per 100,000, but in India, the incidence of colorectal cancer is still 5 per 100,000. So that is what it is as of yesterday on the Globacon 2022 website. So now, if we have this low incidence, how does it affect screening? What does this low incidence imply? So now, all the results from the Western trials may not be the same in India, because the incidence by itself is low. If you look at the flexible sigmoidoscopy study, they had a 12% adenoma detection rate. Now, if our incidence is low, our adenoma detection rate is going to be extremely low, because our incidence is 10 times lower. So we'll have a higher false positive test rate, because our true positives are going to be less. Now, if you're going to do invasive procedures, the complications will occur, and sometimes the complications may actually outweigh picking up a single positive test. And then if our incidence is low and the pickup is low, again the cost-benefit ratio is completely changed. So will all that I have spoken to translate to a good outcome in India? The answer to that is, I don't know. I have my doubts, and I welcome all your thoughts. This is data from CMC Vellore, from Kanyambadi block, which is the block taken over by our community health center. This is a population of about 116,000 people, and this is the death in the last 5 or 6 years because of colorectal cancer. And you can see that there's only about 3, 4, 5 deaths per year. So you've got, and which is about, states to the incidence of about 5 per 100,000. So now, are we really willing to invest in screening 116,000 people to prevent 2 deaths or 5 deaths? Is it really worth the effort? Or should we put our effort into early detection and diagnosis and treatment? Now, the other big difference from the West is the population structure. We have a predominantly young population. The median age of the Indian population is 28 years, which is very different to the Western population. A large proportion of cancers in India are in the young. And screening is usually done for 50 years and above. Now, I know that there are parts of the world where we are considering reducing it to 45 or even 40. But our population, we will still miss a lot of cancers if we screen only at 50 and above. It's not that the incidence of cancer in the young people in India is high. We just have a lot of young people, and so the absolute numbers are higher. Now, lowering the age of screening will have a huge implication on logistics and cost. So if you look at this is the population pyramid of India, and this is the population pyramid of UK. I have put an arbitrary line at 50 years here. So if you see, there's a huge proportion of people above 50 here. And this is the primary place where you get colorectal cancer. Now, we have very few people in this age group where we are going to have colorectal cancer. Now, we have a large proportion of people in this group where the incidence is low, but the absolute numbers are still going to be high. And those are not going to be picked up by screening. So those are not going to be helped by a screening program at the moment. Other thing is infrastructure and expertise. Now, FOBT positivity is about 1.5% to 2%. Now, all these patients require a colonoscopy, and a high quality colonoscopy with ability to remove adenomas, if at all. Do we really have that kind of an infrastructure? In villages in India, in small PHCs, can we offer high quality colonoscopy with a low complication rate to 1% of the population? And I think that's almost impossible. Patients will want to travel to get this done to 100 kilometers away to STG. And we don't have the infrastructure to deal with the complications of this endoscopy. So in trying to do a good thing, there's a risk of doing harm. Financial aspects, of course, the current infrastructure does not allow flexi-seq colonoscopy or CT colonography to be possible because it's not cost effective. FOBT and FIT is also expensive. I'm sure if you use it regularly, the costs will come down. But if the incidence is low and your detection rate is low, does the cost really justify do the detection really justify the cost? Uptake is going to be a problem. India has a very diverse population. We have rural villages, we have big cities. The uptake is going to be there are people at various education level, SES levels. Are they all going to uptake screening? What kind of strategies will we employ to get everybody to actually screen? So just to recap, we have a low incidence. The benefits of all the Western trials may not translate. Cost per cancer detection is higher. Complications and false positives are going to be higher. We don't currently have the infrastructure to roll out a national screening program. We have a younger population with a very different demographic, which may not benefit from screening. And large-scale delivery and uptake are really going to be challenging. So to answer this question, which was put to us, screening for colorectal cancer, is India ready for it? India is probably not ready to adopt the Western model of screening. Large-scale population-based screening studies are needed to see whether this thing will actually work in our population. Local estimates of cost effectiveness are required, infrastructure development required. If we don't have all this in place, I don't think we can roll out a national screening program. Having said that, however, I still think that opportunistic screening can and should be offered. If somebody walks into your clinic, or if somebody comes and says, should I get screened? I think people should get screened if they can pay for it. If the infrastructure is available to do a colonoscopy and to deal with the complications, yes, we should offer opportunistic screening. Screening should definitely be offered to high-risk groups. Dr. Rama spoke about hereditary cancer colon patients. Anybody with a family history, anybody who wants to get screened, definitely we should offer screening. A better way to go around probably would be in early diagnosis, making people aware so that we catch people early and we then therefore treat early and don't get the advanced disease that we see. And that will involve education of public as well as general practitioners to refer to surgeons early. Because very often actually patients have been to a doctor and been treated for something else for 6 months before they actually come to a surgeon or a diagnosis is made. And then of course there are specific subpopulations where the limitations I have said don't exist and screening can be offered. It can be a hospital offering screening to all its employees. It can be a particular company offering screening to all its employees. In big cities, screening can be offered in certain subgroups. But population screening, I think, is still, we are a bit away from that. Thank you.
Thank you, sir. You have debated well for against screening for these things. The discussion is open to the floor. Actually, my comment is, yeah, we are not ready, but urban India is almost westernized, and rural India is almost another 10 years is getting westernized. Yes. So we are going to see a huge rise. I think yes. Dr. Saklani can also comment.
The reason behind this topic was that our own clinical experience shows that in our OPD we see hundreds of rectal cancers, and very rarely we do see early rectal cancers. It's still about 90 or 95% are locally advanced or very locally advanced rectal cancer, which even without all the screening modalities, you can easily diagnose them at an earlier stage. And as you rightly said, most of these patients would have been under some sort of treatment for some anorectal diseases for the last 6 or 8 months. So I agree that we may not be able to roll out a screening for the population as a whole, but probably early diagnosis or educating our surgeons or the physicians or primary care physicians about the early diagnosis of at least rectal cancers would have I get depressed when I see hundreds and hundreds of locally advanced rectal cancers, very locally advanced, not the T3s, all T4s and N++. That's the reason.
Absolutely. And I think that is important. One is early detection. Screening also, there's a lot of India which is very westernized, which is very urban, and probably screening in that subpopulation may work. If you're looking at Mumbai or if you're looking at big cities, yes, screening may work. Again, the caveat to that is we see a lot of young patients with rectal disease. They are not the ones that we actually will be screening, because screening starts at 50. So, and also there's a strong bias when we work in tertiary care centers versus what happens in the community. In our OPD, we will see 20 rectal cancers, 30 rectal cancers every week. But if you work in a small hospital in a community, you'll probably see once in a month, because there's a strong referral bias that we see.
I feel Madhurli sir has rightly given the topic, but I think the topic can be modified to Kerala, because yes. The incidence of colorectal cancer, it gets diluted a lot when it compared with the whole of India.
Absolutely.
The incidence, that graph showing European population and UX population, I think Kerala would stand very close to it when you say colorectal cancer. So screening is absolutely an important thing, but again, cost effectiveness.
Yes. So again, India is so diverse. I think you have to look at subpopulations. And if there is a subpopulation where the incidence is high, definitely screening can work.
And Kerala is a country, God's own country. So. Anyway, a little away from this, Rohin. Excellent talk. You always talk well. And one more of that. See, we have been analyzing. It's very disheartening to understand a software engineer who comes to you after 36 transfusions for a right colon cancer. And it's not uncommon in the institutes. 36 transfusions done by a MD general physician. A male patient, young patient, would not be having a less than serious cause for anemia for such a long duration. Colonoscopies are not done just because the patient is young. So it's important to understand that before you really strategize all this, we must really reach the surgical oncology community colorectal surgery community should reach these people to say, if necessary, the public, anemia, yes. Especially in a male patient, one of the causes can be this.
Yeah.
Because
absolutely.
when we were analyzing, the lag between the patient's symptom. You talk about asymptomatic people, please come and get colonoscopy, and you neglect the symptomatic people, seriously symptomatic people. So it was ranging, actually one of our boys is analyzing this. It ranges from generally a minimum of 3 months to 11 months actually.
Absolutely.
So it's disheartening, isn't it?
We see so many people with recurrent transfusions,
Correct.
so many people with right colon cancer who had a lap chole.
Correct.
The symptoms are always of a right colon cancer,
Correct.
but there was a stone on the gallbladder and they've had a lap chole 6 months ago. We see so many patients with rectal cancer which is palpable on a digital examination,
Correct.
but have been treated for hemorrhoids without even having a rectal examination or proctoscopy being done. And I think this is what we have to educate both the public as well as the general practitioners to say that this is the you treat for hemorrhoids, you have to do a rigid sigmoidoscopy or at least a rectal examination. If you if somebody has anemia, we have to have a colonoscopy. So that is going to yield much more fruit in the Indian context
Correct.
than a population screening.
And I think as professionals, we have much more responsibility to responsible patients. Is it not?
Absolutely.
They're responsible, they're seeking help, but still you are killing them. So not allowed.
There's a whole heaven and earth difference between how colorectal cancer specialist looks at screening and how a public health professional looks at it. See, in India, we are not able to implement universal screening for breast cancer and cervical cancer. So I think colorectal cancer screening is probably decades away, if not centuries away.
So the data that I presented from CMC, we were looking at 2 cancers. We were looking at, there's a public health professional who's looking at this, and we are looking at cervical cancer and colorectal cancer to see if we can introduce it in the community. Now, cervical cancer, one thing is it can be done in the PHC. The second level test can also be done in the PHC because it's only a biopsy or an ablation. Whereas for colorectal cancer, you have to go to an institute to get a colonoscopy. And that makes a big difference in uptake in the community.
That's true.
So if you don't put your finger into the rectum, you will put your foot in it. At least a digital rectal examination followed by, if required, the fecal occult blood or FIT. I think nowadays FIT is more specific.
Yes, definitely.
I think true. I think primary healthcare services have to improve, so general doctors have to look after. Even if you do an ordinary surgery, iron deficiency anemia should be investigated. But there's a difference in screening program. In India, it's more like US. So if you want to do screening program, the national screening program won't work. So you can say FIT can be recommended over the age of 45 or 50, and all these corporate people actually do come for things, and the FIT can be done. So in this group of people, at least you will have outcome. But these are, of course, more conscious people, so they definitely will have a better outcome. So while the national screening program can't go, but it can be recommended as an association to FIT for over the age of 50 or something. We don't know what is the cost implications and things, but that can be
in
started.
subsets, yes. So like you said, a corporate can say, a hospital can say, a company can say, we are offering screening to everybody, and people can take it.
So it can be recommended, but
Yes.
not national.
But as a national program, I don't think it's feasible at the moment.